Hi, I'm Dr. Martin Rutherford,
I'm Dr. Randall Gates.
and today we're going to talk about cutting through the BS relative to chronic fatigue syndrome.
What we've seen with chronic fatigue is that so many patients come to our clinic with a preconceived notion that chronic fatigue is one problem or it's one thing. The most common being it's all Epstein-Barr virus, or it's Lyme disease, or it's just the thyroid. In all reality, cutting through the BS is that chronic fatigue is a multifactorial problem. We'll talk about today that there are really 8 to 9 different physiologic abnormalities that create chronic fatigue, and they're different for most of our patients. The interesting facet of our treatment program is that Dr. Rutherford suffered with chronic fatigue for a number of years. So I think it would be good to turn it over to him and let him explain to you what he went through, because you may find that there is some commonality between what you suffered with and what he has suffered with. And the nice part is that you've come up against a lot of the skepticism, because so many people who have chronic fatigue are told you're fine or you're just depressed, pull up your bootstraps, and here you are, a doctor, and you're hearing some of the same things from loved ones. And maybe take the audience through your experience with chronic fatigue.
Yeah, well, it's been very helpful to have been on both sides of the game here as far as you go relative to chronic fatigue. I actually lived in the town up in Incline Village in Nevada, where the doctor developed the theory, and not entirely incorrect, that Epstein-Barr virus was the cause, the one and only cause of chronic fatigue, and that you had to kill the virus, and so on and so forth. But my fatigue started rather quickly, and in our world, and you may hear through this presentation, that when fatigue kind of sort of starts quickly, when it seemingly comes out of nowhere, usually one of the 8 facets you're going to find out, or 9 facets, is there's usually an autoimmune problem involved. And indeed, that was the case with me. But I was under a lot of stress. Stress can be a trigger for some of the causes of chronic fatigue. I didn't know that at the time. Prior to me developing this fatigue, most people would agree I had the energy of 2 or 3 people. I wouldn't sleep all that much. I'd work all day long. I'd work 7:30 in the morning until frequently 6:45, 7 o'clock at night. I was active and outside of the office, and so on and so forth. And then I went through this period where I was going through a lot of, we'll say, emotional trauma. And part of the paradigm that we've developed here, you're going to understand emotional trauma may be significant to your case. And then I developed, I was under that stress, and then I developed pneumonia. You'll find out that one of the triggers for chronic fatigue can be overwhelming infections. I developed pneumonia, and the next thing you know, I'm on my back for 3-4 weeks. I developed this chronic fatigue, and we've later found out that I did have a positive Epstein-Barr virus. And in retrospect, when we find out that there's a positive Epstein-Barr virus that lasts for like a year or more, that means something. I'll leave it to you to explain to them what that means later. So anyway, in the end, I had a difficult time recovering. Suddenly, I was profoundly tired. All I could do was lay on the couch. I wanted to get up and go to the kitchen. I couldn't get up and go to the kitchen. It was very difficult for me to go to work. At the time, I was working as a chiropractor. And so I was working on patients all day long. Oh my God, I was physically moving people, and so on and so forth. I'm here in Reno, Nevada, and most of you may not know that back in the 70s and 80s, Reno, Nevada was the alternative mecca in all of the United States. And as a result, we have a lot of alternative doctors here, mainly alternative medical community doctors. And I knew most of them at that point in time. So I went from doctor to doctor, and I got, and as I said, the gentleman up in Incline Village, whose name I'm not going to mention, is, because this might sound derogatory, but it's not meant to be, who discovered that Epstein-Barr virus was the condition, or was the cause of this condition. I kind of knew him through another person. I kind of interviewed with him. I wasn't into the drugs at that point in time and his position was take a lot of medications. So I went to the alternatives. and the alternatives were still carrying the, okay, it's a one-cause deal. So a lot of the alternative medical doctors were, okay, it's Epstein-Barr virus, we're going to do the same thing he's doing. I said, well, I don't want to do that. Well, then it was, okay, but it can be heavy metals. Oh, okay, so I took the metal out of my mouth, I did all the chelations, and then it was like, okay, that didn't work. Well, it could be your thyroid. Here, take some iodine and take some tyrosine, and I got worse. And then it was parasites, and then it was adrenal fatigue. Of course, you've heard that one, and you're going to hear in this broadcast how we've written articles on how the adrenals are the wrong target in this particular type of a thing. So basically, I went through all that, and I was pretty active, and I've always been pretty athletic all my life. And at that point in time, it was to the point where not only could I not do more than 10 minutes on a treadmill, and I used to do an hour on a treadmill after I would go to the gym and work out. And I didn't even consider it part of my workout, but I'd do it for an hour. I would only be on there for like maybe 10 minutes, and then I would crash. And not only would I crash for like that day, but I would crash for like 2 or 3 days. And so this started to get pretty concerning. And then my journey ultimately took me to do some research, as many of our patients say when they come in here, do some looking around on my own, and starting to run into some of the people who were developing some of the theories and understandings that we have embraced today, and have found that have kind of congealed into a usable understanding relative to being able to take a good history on a person, to really do the proper exam, know exactly what type of testing you should be doing, and then ultimately walking them through a procedure that frequently can produce a successful result in getting that under control. Today, I'm here. I work every day. I work hard. I don't know if I work as hard as him, but I work hard. For my age, I'm right on 65, coming up on 65 here. I can golf. I can do, I can go out and walk 18 holes, and I live a normal life now. There's certain things that I need to not do. I can't go to the gym for 3 hours anymore. But I live a very normal life, and my brain is good, and I feel good, and so we were waiting until we had these understandings, and we were certain about what we were seeing and what we were doing before we started to present this material to the world. Mm-hmm. And so that's kind of my story. I mean, my story is very long, and you don't need to hear the entire story, but that's the gist of it.
It is, and we're going to do a few aspects to this broadcast. Next, we're going to go into Dr. Rutherford's office, and he's going to go through a lot of the historical features that many of you present with who have chronic fatigue, and maybe some of the missing points that have not been addressed in evaluation of your case, because there are certain elements of the neurological history that are very, very important for a lot of chronic fatigue patients, and lots of times that's just glanced over on. And then I'll be going through really the science and the nuances of chronic fatigue. We'll have peer-reviewed references, scores of them, up for you to look at as we go through this chronic fatigue broadcast, and I'll try and coalesce together some of the aspects of Dr. Rutherford's history and bringing you that science to kind of parlay and bring these elements of the story together. So I think next, let's go into your office so we can do the consultation.
Okay. So the purpose of the No BS series is to try to bring more clarity to people who have these conditions as to why maybe they've gone through what most of our patients have gone through by the time they get here. There's no silver bullet. There's no one-shot-fits-all type of protocol to take care of chronic fatigue. I can talk to you through personal experience on that. Multifactorial means that that you need to be an astute diagnostician to find out which of the multiple different causes and vicious cycles that are involved in the physiology of the chronic fatigue patient are there, and how to go about that. The way you do that is through first understanding what they are, And if you go to a doctor who doesn't understand what they are, you're going to get the one-shot deal type of a protocol. And you have to understand what they are. That sounds obvious, but you have to understand what they are to do a relevant diagnosis. In our office, we do a very comprehensive consultation to begin with to determine whether the patient's even a candidate for what we do, because there are some types of individuals that will not do well in this type of a program. Okay, but overall, it's more to establish what the diagnosis might end up being in that particular person. So first, you have to understand that there are 8 or 9 different things that can be going on, and then you can craft a history for that person. And that history is usually going to start from the very beginning of their life to the end. And so we start out with the understanding that chronic fatigue, you're going to be listening for thyroid symptoms, mismanaged or misdiagnosed thyroid, mismanaged or misdiagnosed blood sugar problems, mismanaged or misdiagnosed stress problems. And we're going to delineate that a little bit more because this is a big key to a lot of chronic fatigue. Mismanaged or misdiagnosed gut problems. Epstein-Barr virus is a player, but we'll clarify that later on in the video. Anemias can be a player. Autoimmunity is certainly a player. Certain bacteria that are in the gut are players. And these are the major players. So you craft your history around that. And the history needs to start at the beginning of your life, because these conditions are not something that just comes out of nowhere. Now, if you come in here and you tell me, one day I just got sick, and next thing you know, I went into chronic fatigue. That sickness was an overwhelming infection, like for me, bacteria. We're going to have certain thoughts on that. We're going to think, oh, that sounds like it might be an autoimmune problem, because autoimmune problems tend to come out of nowhere. Okay, but more than that, we're going to say, well, you know what? You were a compromised host at that point in time. In other words, you were already compromised by either having a genetic propensity to develop an autoimmune problem, or maybe you were under chronic stress at the time. Maybe you had emotional trauma when you were a child. Maybe you had already had a bad gut for years. My case. I had a bad gut. I had my first gut surgery when I was 5 years old, or 5 weeks old, when I was 5 weeks old. So I had a bad gut. Today we know I probably had a leaky gut, intestinal permeability from that point on. I always had bad intestinal problems, always. I can remember having a pass to go to the bathroom in 3rd and 4th grade because I just had to go so much. So I always had bad gut problems. I took antibiotics. Antibiotics didn't help my gut problem. As you might know, that changes the flora of bacteria in your gut. At 21, I developed ulcers when I was a teenager. So bad gut. At 21, I get mono, which is caused by Epstein-Barr virus. The mono lasted forever. When a person gets mono, it should last for 6 weeks. If it lasts for more than 6 weeks, that means something. Mine lasted for about 14 months. I was not even able to get on a treadmill for more than 10 minutes. And I was pretty physically active at that point in time. I got on a treadmill for 10 minutes, boom, I would collapse. That is an indication, in my case, that not only did I never recover my energy levels, although my energy levels were still sufficient, but I never recovered them, that at that point, the causes of my later fatigue had already kicked in. In the end, that would indicate me having that mono for more than 6 weeks. That would indicate to us a probable attack on the thyroid. And indeed, I started to have to fight my weight at that point. That was at 21. And then I had those problems for many years. And then at 48 is when I got the pneumonia. I was under a tremendous amount of stress, and then everything blew up. In addition to chronic fatigue, I had fibromyalgia, peripheral neuropathy, celiac, Hashimoto's thyroiditis, a number of things that all were either caused by or contributing to the same things that were causing the chronic fatigue. So this is how you take a history. You are looking for aspects of those 8 or 9 issues that we talked about in that person's history. And you look to see how the dominoes fell in that person's life. And from there, you can see which systems that were in the framework of the 8 or 9 that we're looking for have already been a problem. Now, the one system I am going to emphasize at this point in time is the stress mechanism. Thyroid, blood sugar, stress hormones, gut, Epstein-Barr virus, undiagnosable anemias, bacteria in your gut. These are the things that we're looking for. But the stress response, I want to get clear on that. I want you to get clear on that, okay? We're not talking about stress. For a long time, as we were trying to break the code on these chronic pain conditions, we thought we were talking about stress and daily stress. But it turns out that what we were talking about are patients who are more or less in kind of chronic fight flight. You could call it post-traumatic stress syndrome. We call it sympathetic dominance. That's kind of the fancy technical medical term for it. But whatever you want to call it, this is a key. This is one of the biggest reasons that people go to very good alternative practitioners and yet their treatments fail. And so when we started realizing that our patients were actually in some sort of chronic fight or post-traumatic stress syndrome, it changed everything. Dr. Gates is a board-certified functional neurologist. His discipline is the discipline that pioneered brain rehab exercises. And they are also the discipline that understood that this stress response was going on in people continually after the event that caused their emotional trauma. And that it kept flooding their system with stress hormones from that time on. I'm going to explain that a little bit more. So here's what I'm talking about. This is your brain stem. This is your brain stem, and your brain stem controls all of your automatic functions, okay? This brain stem controls your breathing, it controls you moving your bowels, it controls your sleep, your blood pressure, it controls all those things. Eyes dilating, contracting, everything that you're not thinking about, okay? The bottom 2/3 keep you relaxed. We have called it the relaxation and digestion area of the brain. It's known as your parasympathetic nervous system for those of you who are more scientifically oriented. So this is the part that controls us and keeps us relaxed. Our normal state is relaxation, okay? Believe it or not, that's supposed to be our normal state. When we're in a relaxed state, everything works better. Our bowels work better. In absence of pathology, our bowels work better, our heart works better, we sleep well, and so on and so forth. Then there's the upper third of this brainstem, and this upper third is where your fight-flight response is. For the scientifically oriented, your sympathetic nervous system. Key point, they can't work at the same time. It's either one or the other. Okay, they can switch back and forth, but they cannot work at the same time. So this area is our ultimate survival mechanism. You hear a sound, you look at the sound to see what it is. Is there somebody sneaking up on me, or was that just like a breeze that was rustling the grass or the trees or something like that? And when we perceive danger, there's a part of the brain called the amygdala, the fear center of the brain. That's important to remember here in a minute or two. And then that fear center sets off this upper part. The relaxation response is then disengaged. And then it sends a signal, this midbrain, where the fight-flight mechanism is, sends a signal down your spinal cord out to the adrenal glands. And again, we've done a number of talks on how the adrenal glands are the wrong target. For those of you who understand adrenal fatigue, there's more to it than that. So the adrenals then start putting out all kinds of hormones, and these hormones start putting you in a position to fight or to flee. So they put out hormones that cause your heart to start pounding more, to push blood through you. They put out hormones that cause your blood pressure to go up, so that the blood pressure can push nutrients like glucose and oxygen, which are coming from you now, breathing hard and getting all this air coming into you, the oxygen and glucose from another hormone that's being told to move the glucose out of your liver into your bloodstream. And now your brain and your nervous system get a big supply of energy from the sugar, from the glucose, and from the oxygen. So these nutrients go to your brain, your nerves and your arms and your legs. They go to your muscles, and now you're strong. You can fight or you can flee. When the danger's gone, there's a part of your brain called the frontal lobe, which Dr. Gates is going to mention later on in his aspect of this presentation. This frontal lobe is supposed to shut this fear center down, and then this sympathetic fight-flight mechanism is supposed to shut down, and then you go back to rest and digest. With almost without exception, the patients in here that eventually find their way here have never gone back to rest and digest. The reason being, and the literature is very, very clear on this, and we see this day in and day out, most of the patients coming here aren't in just a simple stress situation. They're in fight, flight, and it's usually from either perfectionism, which kind of blew my mind when I was first exposed to that data, but more so from emotional trauma. Emotional trauma could be being physically, verbally, sexually abused. It could be from a traumatic lawsuit. It could be from maybe not feeling loved by your parents. It could be from a terrible divorce. It could be by somebody sticking a gun. I just had somebody here a couple of weeks ago. I said I had somebody stick a gun in my head and pull the trigger, and I thought that was it, and the trigger, and it didn't work. Any of these things that stimulates the fear center and is an emotional trauma literally gets programmed into there, because your fear center is kind of the sentry at the gate of your emotional system. It's called the limbic system. So your emotional system, it's like your emotional system never wants you to forget that horror. If you were raped, if you were physically abused, if you were verbally abused, it's like your brain doesn't want you ever to forget that, okay? And so now this whole mechanism keeps going, and that is not a good thing, because when stress hormones keep pulsing through your system intermittently on a daily basis, the things they can do is manifest. There's so many of them, and they have to be considered in virtually every chronic fatigue problem, because they can come back and go to a part of your brain called the hippocampus, which can primarily cause brain fog, and it can cause short-term memory loss. But short-term memory loss changes into long-term memory when you sleep. So this hippocampus also controls your sleep. Can't go to sleep, wake up, can't go back to sleep. That will make you tired. That will contribute to fatigue. These stress hormones will also damage frontal lobe function. Your frontal lobe is who you are. If you're happy, if you're sad, if you're motivated, if you're not motivated, if you're very social, if you're not social, it's your learning areas. This frontal lobe gets attacked by stress hormones, and it's one of the things that'll make a frontal lobe not function right. And if it doesn't function right, usually what you're going to see in a chronic fatigue patient is depression. Depression is not a personality disorder. It is an abnormally firing frontal lobe. And the frontal lobe needs a number of things to fire right. When it's not firing right, you will get depressed and you will get fatigued. Okay? It can actually create, stress hormones can actually create the immune inflammation that causes an attack on the thyroid. It's one of the three things that can cause Hashimoto's thyroiditis, which is a hypothyroid situation in which you actually have the immune system attacking you. Hypothyroid or Hashimoto's will contribute to fatigue. Fatigue, my hair is falling out, short-term memory loss can be caused by that, and sleep mechanisms can be caused by that too. It can affect chronic sinus problems. It can cause chronic lung issues. These are the stress hormones. And it can cause your entire gut to be off. It can damage your ability to make hydrochloric acid in your gut, so now you get acid indigestion. More importantly, maybe you're not breaking down your nutrients, so you can't absorb iron, you can't absorb B vitamins, you're not breaking down your proteins. That'll make you tired. It can be that because you don't have hydrochloric acid in your stomach, because the stress hormones are causing you to kill the cells in your stomach that make hydrochloric acid, it may be that now you can't kill bacteria. So now you get small intestinal bacterial overgrowth in your gut, or you get candida, or you just get inflammation, or you get something like that that's going to cause your gut to be sick and not absorb foods or to emit toxins to the rest of your body that are going to affect systems that are going to create fatigue. These stress hormones affect your sex hormones. So in a woman, it'll actually increase testosterone and decrease estrogen. Why? Because the stress hormones are being made out of the same chemicals that make your estrogen. So if estrogen goes low, testosterone goes high, you can ultimately get depression because no estrogen to your frontal lobe. What happens when a woman gets depressed? First thing they do is they give you estrogen for your frontal lobe. This is the answer, not that, but that lack of estrogen to your frontal lobe will cause fatigue. That can cause insulin resistance. Okay, and the stomach can cause insulin resistance by changing your testosterone, or in a woman, by changing your estrogen into testosterone. So now again, another mechanism, and on and on and on. Frankly, these stress hormones are one of the biggest causes of chronic urinary tract infections, chronic cystitis, and I can go on. The point I want to make is, if you have this chronic fight-flight syndrome, this was the big X factor for us. When we realized that simply fixing the gut, simply addressing the adrenal glands, simply trying to do the thyroid wasn't working, or it was working sporadically, or wasn't working intermittently. When we finally started to realize that patient's stress hormones were continually flooding them and they were sabotaging everything we were trying to do. You're trying to fix the gut, but the gut's inflamed. So how can you fix an inflamed gut that's being inflamed by stress hormones? You're trying to fix somebody's thyroid, but the actual cause is stress hormones hitting the thyroid. How are you going to fix that with even supplements or drugs? You're not. So this is the thing. These are the things that I look for in the history. These are the things that we need to understand. Can we help that patient? Do you have these 7 or 8 problems? Is it really chronic fatigue, or do you have some sort of a pathological problem that needs to be referred out to somebody else? So doing the history is very important. And are you a qualified patient from, let's say, not a pathological or not a functional perspective? Those are all functional abnormalities that I just detailed. Your thyroid's not functioning right, your gut's not functioning right. Those things, if the patient has those, then they can probably be helped. And you can now understand why I said you could have 100 patients in here that have chronic fatigue, and all of them will be slightly different. But also, the patient has to embrace this model. They have to embrace the model of that it can be done without drugs for the most part. Some people have to embrace the model that maybe they might have to take a medication for their thyroid, so on and so forth. The biggest challenges seem to be embracing and understanding the fact that this stress response is significant. Another big qualifying factor, and we have signs all over the office here that say, we didn't say it was going to be easy, we said it was going to be worth it. And to that end, your diet, this is a lifestyle change, and most people perceive lifestyle changes today as diet and exercise, and certainly there are very precise, very specific dietary changes for each individual patient that comes in here. But if a patient is not going to be able to stop eating some of their favorite foods, because those are usually the foods that they're allergic to, allergies can inflame immune responses. Immune responses can contribute to chronic fatigue. That's going to be a problem. If that person has an unsupportive environment around them, that's going to be a problem. If their spouse isn't on board with either the idea that this can be done, or the spouse isn't on board with the fact that they're going to change their diet, and maybe they're going to have to cook for them, or they're going to cook and the spouse is going to have to try to eat a similar diet. Things like those aspects of that person's personal life can make a difference as to whether they're going to be able to actually get better or not. And I'm saying all these things to help you to understand what we have dug through over the last, oh my goodness, like 10 years at least, to figure out all of the aspects that a person needs to have to first understand what their case is, and then understand, is that person going to be a good candidate for this program? And usually once we do the consultation, we can tell pretty much whether the patient should be further evaluated. And because at that point, we know that if that person's on board, and we know what that person probably has, we know that if we go ahead and do our evaluation, that we're going to narrow it down even further and get more specific with our diagnosis. And we know that if that patient decides to do what we ask him to do, determined by this exam and history and further testing, that by and large our patients will do well. So that's how we determine whether the patient should go ahead with the exam. That's how we determine what's wrong with the patient. And so the examination is now going to be done, and the examination is going to now take this basket of potentials. This person has thyroid, this person doesn't, this person has gut problems and stress responses, this person doesn't, this person's gut has all these things. It's going to take all of that, and it's going to start to narrow it down into even a more acute focus. So why don't we now go to Dr. Gates, and Dr. Gates is going to discuss many of these concepts in much further depth. As he mentioned, there will be peer-reviewed journal references for the more research-inclined or the more academic attached to the end of this presentation, so that you can look and see that everything that Dr. Gates is going to tell you is going to be based on pretty much solid research. And he can go through with his aspects of the exam and how they contribute not only to the diagnosis, but also clarify how we would go forward with any particular case and the more specific aspects of how you would handle those cases.
So now that you've seen Dr. Rutherford in the consultation room discussing the historical features of a chronic fatigue patient, now we're going to get into more the nitty-gritty details, so to speak, and how we assess a chronic fatigue patient. Now, anytime you're evaluating a patient with chronic fatigue, you have to be thinking, are there ominous problems or more severe problems causing the chronic fatigue, or is this more, as they term, functional in nature? Functional nature would maybe mean gastrointestinal dysfunction, mitochondrial dysfunction, problems with the thyroid. But some of the more serious factors that have to be addressed when you're evaluating a chronic fatigue patient are, does this person have leukemia? Leukemia can cause fatigue. Or do they have what's termed postural orthostatic tachycardia syndrome, which is where people will be sitting down, they'll be fine, they stand up, all of a sudden their heart rate goes up above 100 plus, and that can be highly associated with fatigue. Are they severely iron deficient, and are they bleeding out? Those are the factors as a doctor that you have to assess. It's important for you as the patient to kind of have those things in mind and say, have I really been assessed for those factors? Now, in the course of your workup, once those factors and those parts of your history and your examination are ruled out, that's where we come into our paradigm of chronic fatigue. And the best way to think of this is that it's a multifactorial problem. We rarely find that there's just one issue associated with your fatigue. And so envision this, envision a boat. And this boat has 8 potential holes in it. And really until you plug each of those holes, an individual's fatigue is not going to be improved. And so that's where a lot of individuals, and you're being marketed to, so to speak, in today's society and the internet world that we have today, where it's just one factor for one problem. So if you have chronic fatigue, take this supplement. Or you have chronic fatigue, you have an Epstein-Barr virus infection, you need this treatment. Unfortunately, we have found the majority of chronic fatigue patients coming into our clinic not to be that simplistic in their presentation. So really the major overall factors that we look at with a chronic fatigue patient include gastrointestinal dysfunction, which could mean the immune system attacking foods in the gastrointestinal tract. It could mean pieces of bacteria getting through the gastrointestinal tract. There's new data on this associating this as a major cause of fatigue. It can be related to your brain chemistry. It can be related to autoimmune problems. It can be related to thyroid dysfunction, including poor conversion of your inactive thyroid hormone to active thyroid hormone. Other factors include chronic infections, as well as dysfunction of the mitochondria. The mitochondria are a powerhouse of our cell. So on that point, it's important to go into that because that's really where we started in addressing chronic fatigue patients. We looked at the infectious model. And so many of you out there have been exposed to that, where you go and see a doctor and they say, Joe or Susie, you have an Epstein-Barr virus infection. or you're reading online, and people will say all chronic fatigue is due to Lyme disease, and so you need to go see a Lyme literate medical doctor for appropriate treatment of those conditions. While we have seen patients come into our clinic who have had positive responses for treating the infections in their body that may be living in the cells of their body, breaking down their mitochondria, which doesn't allow them to make energy, we have not found that to be the majority of the patients coming into our clinic. Possibly that's because we see more difficult patients who have tried everything and been everywhere and haven't had success. So the mitochondria do have to be considered. After we started looking at the mitochondria and realizing that even with treating the infections or repairing the mitochondria, that was not the whole solution, then we started dovetailing into the thyroid more and more and more. What we found is that a lot of you have been tested for your thyroid and told your thyroid is normal, but with that, lots of times not all the tests have been run. So most of the time when you get a test for your thyroid, you're getting a hormone from your brain to your thyroid, and if your thyroid is low, that hormone's going to go up. Usually you get that test and maybe a test of the inactive thyroid hormone that's produced from your thyroid gland. But when we run a thyroid panel, we run 8 different markers on the thyroid because you have to dig deeper. We have found a lot of patients to be normal on their thyroid panel, which are those 2 markers I just referenced. But they're abnormal when you look at their conversion of inactive thyroid hormone to active thyroid hormone. And most of that conversion occurs in your gastrointestinal tract and your liver. Very interesting. And we've addressed those issues with patients, and yes, we saw some success. But again, that is just one hole in the ship, so to speak. Another important factor to look at relative to the thyroid is the immune system attacking the thyroid. Again, so many of you have not had the immune counts to your thyroid checked or evaluated under the correct criteria. For example, the Mayo Clinic has a much more stringent criteria, even our local hospital does, for evaluating this autoimmune problem to the thyroid, versus LabCorp has a very wide range. And so many of you, even if you have this test done, are going to be told that you're normal, but you're not normal. And just for some frame of reference, this is called Hashimoto's thyroiditis. And when your thyroid hormones are normal, it's called euthyroid Hashimoto's thyroiditis. And the new data is showing that just the immune attack on your thyroid, even when your thyroid hormones are normal, can be highly significant to symptoms such as brain fog and fatigue. So this has to be critically evaluated. And so when we're evaluating a thyroid patient, the next question is, well, why is the immune system attacking the thyroid? And from that, we see that the immune system is oftentimes attacking the thyroid because of food reactions in the gastrointestinal tract. Well, foods are getting through, as well as viral infections living in the thyroid gland itself. But there is some thought that the viral infections within the thyroid gland itself are there because the immune system is so overreactive to the gastrointestinal tract that it's not allowing the immune system to see the viruses living within your thyroid. And then going on that point, there's new data associating pieces of bacteria getting through your intestines. When these pieces of bacteria get through your intestines, it's called subclinical endotoxemia. And this can be a source of fatigue in and of itself. So we have had patients come through and they've been on restrictive diets, and it wasn't until we started killing off bad bacteria in their intestines that their chronic fatigue all of a sudden began to lift. So that is more the metabolic approach in evaluating a chronic fatigue patient. And while we had success in doing that, our major successes really came when we focused on the brain and neurological function as it pertains to the chronic fatigue patient. And in this part of the discussion, we're going to talk about also the infamous adrenal glands, because so many of you have been told if you don't fix the adrenal glands, you're not going to fix everything. And hopefully we'll be able to elucidate why the adrenal glands really are the wrong target, and the right target is your brain. So that's what we're going to talk about next. So while we found that addressing the thyroid gland to thyroid conversion, meaning conversion of inactive thyroid hormone to active thyroid hormone, addressing autoimmune factors to the thyroid gland itself, food reactions in the gut, pieces of bacteria getting through, as well as the mitochondria and potential intracellular infections that were causing the mitochondria to break down. All those factors are important and really are still part of our differential workup of a chronic fatigue patient. When we coupled those treatments with treatments directed at the brain, we've had the greatest success. And so it's really important for the CFS sufferer to more understand their brain and how it relates to their condition. And so many of you have been to your medical doctor and you've told them that you're fatigued, and they immediately tell you that you're depressed, right? Because so many of you have told us that. And they want to put you on an antidepressant. And then the common response I hear back is, I'm not depressed, I'm fatigued. You don't get it. Well, there's overlap between those two conditions. And we're not saying all of you are depressed by any sort of the imagination. But it is more important for you to understand how stress signaling patterns from your brain to your adrenal glands and then your adrenal glands back to your brain can be abnormal in a lot of your individual cases. A more important point for a lot of you to get is that the vast majority of chronic fatigue patients that we see either are perfectionists, they're under extremely stressful circumstances, they're not sleeping, and or they've been exposed to childhood trauma. Now, childhood trauma is a very sensitive subject, and even in the research, they discuss how frequently patients have never admitted these sorts of events to their doctors. They don't want to talk about them because there's a tremendous amount of stigma associated with childhood trauma. People don't want to complain, so to speak, and a lot of people that we talk to, when they tried to discuss their childhood trauma, were almost lambasted or told that it was their fault. And it's really an immense travesty for an individual to be exposed to those circumstances. But when we're attempting to address your condition, we have to fully get into and understand if that has happened, because it changes neurochemistry, it changes stress firing patterns in your brain, and it really changes how your brain functions in total and how your physiology is disrupted because of these issues. They've even shown in research articles that if an individual has been exposed to childhood trauma, they're 6 times more likely to develop chronic fatigue syndrome. So it's a really, really important point. And the reason why it's so important is that when we're exposed to trauma at a young age, we have an area in our brain called the amygdala. It's deep in the center of the brain, next to an area of the temporal lobe called the hippocampus, which really is your memory area. And the hippocampus and the amygdala serve as like a ham sandwich, so to speak. So they're right next to each other. And this amygdala, we have it there so that we can sense a dangerous situation. So if you're out in the woods and you see a bear, or if you're walking in a dark alley and there's a big tall figure coming at you carrying something, your brain through the amygdala can sense what's going on and will immediately prep you to either fight or flee, called flight, from that situation. When an individual is exposed to traumatic circumstances when they're younger, that amygdala gets primed and it gets bigger if this trauma especially keeps happening. And so what happens is the amygdala then connects to a little gland, as you know, the adrenal gland on top of your kidneys, that make a variety of adrenal hormones. And these adrenal hormones have a tendency to then be too high. They're overfiring and they feed back to the brain, to the frontal lobes namely, and they can actually cause frontal lobe neurons they can cause frontal lobe neurons to degenerate, as well as neurons, little brain cells, in your memory area of the brain called the hippocampus, which is right next to this fear center. So now we have this situation where this fear center is not being shut off. And especially when you look at a child, their brain is not developed already. Their frontal lobes are not going to develop until they're somewhere between 19 and 25 years of age. And so you have frontal lobes that are not developed, you have these tremendously fearful circumstances that then are creating lots of stress hormones that are feeding back and damaging the brain further, allowing this fear response to be overactive. Or you take the case of the perfectionist. And the perfectionist, they live their life by always being afraid or attentive to potential things that could be going wrong. They're always hyper-vigilant, so to speak. And so the perfectionists they've seen, they can actually have increased activation of the amygdala and a similar chemical profile with the adrenal glands. Now, the important point for the chronic fatigue sufferer is that even though they may be exposed to this childhood trauma and have high levels of stress hormones, very similar to the perfectionist, through time, their cortisol is going to become low, but their adrenaline will stay high. So at that point, we need to look at adrenal physiology. So the adrenal glands again, sit on top of your kidneys. These adrenal glands make a variety of hormones. Think of the earth and how the earth has a crust to it, and then the earth has a core to it. The adrenal glands are much the same. So your adrenal glands have the crust to it, which makes hormones like cortisol, or hormones like progesterone, or DHEA. Whereas in the center of the adrenal gland, we have the core, which makes like adrenaline. Think of norepinephrine and epinephrine, but we'll just say adrenaline for the sake of this conversation. Now, if you've been stimulating your adrenal glands chronically, the crust, or the outer portion of the adrenal gland, can fatigue, is what the thought is, whereas the inner core does not seem to fatigue. But they're doing studies, and they've shown that in patients who've been exposed to childhood trauma, that actually genes get changed in their brain for sensing cortisol. It's very, very interesting. And some of these genes can be changed even with depression, because depression will have a similar physiologic makeup between the brain and the adrenal glands. But commonly with depression, not all the time, but commonly with depression, the cortisol will keep staying high. But with a chronic fatigue patient, the cortisol will become low, because when genes change their expression in the brain, you're not going to be able to sense cortisol as well. So basically, cortisol receptors are going to become abnormal. And when they become abnormal, your brain is then going to stop as much signaling down to the adrenal glands, so cortisol will become low while your adrenaline levels can remain high. That's a really, really important point, because when adrenaline is high, it can have all the nasty physiologic functions of high cortisol. So high adrenaline can affect your immune cells. That's been shown in chronic fatigue patients. So going back to how all of you seem to have Epstein-Barr virus, or all of you seem to have autoimmune dysfunction, or even one research article that we're going to attach to today's broadcast quoted 60% of chronic fatigue patients have some form of autoimmune response or abnormal autoimmune signaling in their body. So that's highly important. And as these adrenaline levels remain high, they can also break down your gastrointestinal tract. So I hope that now you're starting to see this web of physiologic dysfunction that so frequently is being propagated or continued on by the abnormal brain physiology. So now let's take a step back. Let's use an example of a chronic fatigue patient. They come in here telling Dr. Rutherford, well, I've been on the paleo diet and it didn't work. I went and I was treated for Epstein-Barr virus and it didn't work. And I had mitochondrial-based treatments, but it didn't work. Taking a step back and looking at their clinical situation, saying, okay, well, you were exposed to childhood trauma, or you're a perfectionist, or you have these high levels of stress in your daily activities. And then we do a neurological exam and we see, oh, and your frontal lobes are not working as well. They're not able to shut off these fear-based responses. So then from that, you can see that this overactivated amygdala, driving the adrenal glands kind of into the dirt, so to speak. Genes have been changed maybe in their brain so that they don't sense cortisol as much. But their adrenaline levels can be high, all the while breaking down their gastrointestinal tract so that the paleo diet didn't work, also disrupting their immune system so it's not seeing Epstein-Barr virus. And the immune system, rather than being able to kill Epstein-Barr virus, is playing like whack-a-mole with it, you would at an arcade as the example. And then the mitochondria are breaking down. Because the gut is broken down, the immune system is still over-attacking the thyroid. That's the classic example of the case that we see coming into our clinic. And it really illuminates how, again, we have potentially 8 holes in the ship. And while we can plug a few holes and maybe an individual will feel better, and we saw that, and maybe that allows you to scoop water out of the ship a little bit faster, until you plug all the holes, in our experience, the holes are not plugged until you thoroughly assess this brain mechanism and how it's causing or perpetuating all of this physiologic web of dysfunction from your thyroid to your gut, to your mitochondria, to infections, to autoimmune responses. So I hope that that makes sense and resonates with you. Now, lastly, kind of to sum it up, so to speak, we want to look at a lot of things that maybe you've been told. So if you have chronic fatigue, you've been told you're depressed, so you need to take an antidepressant. Or maybe you need to take Adderall, so to speak, if you've seen your general practitioner. Or then you go and you see the alternative practitioner who wants to treat the Lyme disease or treat the Epstein-Barr. give you IV vitamins and minerals because you're depleted, or they want to chelate you because these heavy metals are causing your immune system to be so dysregulated. Hopefully you see in those models, those are more just patches. And we even do broadcasts on how chelation we feel is an over-extrapolation for autoimmune responses, but we'll get into that at another time. Needless to say, you have the other model, which is the functional medicine and the functional neurology model, which is really designed to get to the big dominoes. And if you can get the big dominoes to fall, which include getting this overactive fear response calmed down, and then you can fix the gastrointestinal dysfunction. So often, at that point, physiology starts to resynchronize. And if it's not resynchronized, if the mitochondria are broken down, there have been studies showing that you can actually repair the mitochondria. But we haven't found that to work until you address these main features. So hopefully this makes sense. All the articles are attached to today's broadcast. So if you're very pedantic or you like the scientific literature, we have it all there. It's very, very exciting data. And it's even more exciting because we utilize this newest data, so to speak, to help chronic fatigue patients get better.
So hopefully now you have a better understanding of what chronic fatigue syndrome actually entails. Hopefully you understand why maybe you've gone through some frustrations of trying to get an answer, or maybe why you've gone through individual treatment protocols for the different things that we've talked about, but why maybe you didn't get that response because now you understand that it's a multifactorial problem. And so we hope that that cuts through what we call the BS for you, and we hope that that gives you a better opportunity to explore the possibilities on your own if you have chronic fatigue, to be able to get better, or for you to share this with maybe your loved ones or your friends so that they have the opportunity to also understand what's really going on with them and seek out some treatment that can be that can actually be effective for them.
So we get requests to evaluate people's cases from all over the globe. If you want us to look at your particular case, you can go to www.powerhealthconsult.com, and on that webpage you can access information on how to get evaluated by our clinic. We hope this was helpful, and we look forward to talking to you soon.